Welcome everyone who has joined us. We'll go ahead and get started. My name is Mandy Pratt-Chapman. I am PI for the cancer control work that we do at the GW Cancer Center, and it's my pleasure to invite you today to Maximizing Coalition Sustainability Through Partnerships, Advancing Cancer Control Planning, Implementation, and Evaluation. So we're going to go ahead and get started here. Please make sure you're connected to the audio. You can connect by clicking on your phone icon. And also make sure that we should have your lines muted, but you can chat in the chat box. You can ask questions in the Q&A. Feel free to access that by clicking on the three dots that you have on your screen. And we'll be collecting your questions and comments for Q&A at the end of the presentation. I wanted to acknowledge that this work is supported by a cooperative agreement from the Centers for Disease Control and Prevention, and we're very grateful for their ongoing support. And today, I'm pleased that we'll be able to offer you several peer examples of resources and successful partnerships to accomplish cancer control planning, implementation, evaluation, and monitoring. And I also asked our speakers today to identify some strategies to adjust their cancer control implementation efforts during COVID-19. So I'm excited that you'll be learning from some of your peers today and their experiences in cancer control, and most recently in kind of pivoting based on the current reality that we're living in. So our first speaker is Stephanie Kennedy-Ray, and she's Associate Center Director at the West Virginia University Cancer Institute, and she's a faculty member in the Division of Hematology Oncology at the West Virginia University School of Medicine. She directs the Office of Cancer Prevention and Control, which includes the outreach, education, and population-based research arm of the Cancer Institute, and she oversees 8 programs aimed at decreasing cancer burden in the state, including facilitation of Mountains of Hope, West Virginia's Cancer Coalition, and she has a special interest in the education and development of healthcare professionals and interdisciplinary team research, as well as addressing patient barriers in medically underserved areas. So I am going to hand things over to Stephanie for her portion of the presentation.
Okay, it looks like I have control of the screen. Thanks, Mandy. I appreciate the introduction as well as the invitation to speak today. Good afternoon, everyone. I know that many of you, like me, have screen fatigue, and so presenting via screen is sometimes a little bit challenging to keep the energy up, but I'm going to do my best. And I'm going to start first by saying that for this presentation, there is no relevant disclosures to make. Before I get started with the presentations, I would like to acknowledge the Mountains of Hope members, the steering committee, as well as the facilitation staff. Also recognizing the West Virginia Comprehensive Cancer Control Program staff and the West Virginia Clinical Translational Science Institute and the Patient Advocate Foundation. All of these are partnerships, key partnerships that I'm going to talk about throughout my presentation. So before we get started, we're going to take a minute to fill out a poll. You should have 3 short questions that are accessible on your screen, and we're going to ask you to answer those now. So it looks like we have a wide variety of people with experience on the call, from a few years to upwards of 20 years. A small percentage of people have funding outside of the comp cancer money that's provided through CDC. And although all 6 priorities that are identified by CDC for comp cancer, everyone, at least one person checked everything, but really there's an overwhelming number of people that are focusing on primary prevention and screening. So we'll just keep that in mind as we go through, but I thought it was important that we take a minute to understand who's on the call with us. So let me start by talking about Mountains of Hope. As Mandy mentioned, this is our statewide cancer coalition. It serves all 55 counties in West Virginia. And really, we see our job as bringing together individuals and organizations to address the impact of the human and economic impact of cancer in our state. We really work to establish partnerships and networking to achieve the goals in our cancer plan. And there's a picture of the cover of our current cancer plan on the screen. But like many of you, we are in the process of revising and streamlining our cancer plan and hope to roll out the next iteration at the end of this calendar year. We are actually moving from 25 aims to 11 and in order to tighten up the work that we're doing. So the Planning Committee asked us to talk about the structure of our Comp Cancer program and the coalition. And so I thought I'd start with the coalition. Our coalition is led by a steering committee of 15 individuals. It's made up by a variety of those who are appointed, elected, and then we have a few standing offices. So the first standing offices are our 4 founding members. There's a representative from the West Virginia University Cancer Institute, the Bureau for Public Health, and right now that seat is filled by our Comp Cancer Program Director. The American Cancer Society has a standing seat as a founding member, as well as the West Virginia Breast and Cervical Cancer Screening Program. The reason BCCSP sits at that founding members table is because when we established the coalition in the late 1990s, the B&C program had a community coalition of volunteers and advocates who worked on cancer control already in the state. And that coalition actually rolled up under and became part of Mountains of Hope. So that from the very beginning, we had a grassroots group of people to join public health professionals and other cancer control officials, as well as advocates. So we feel like we had a strong base to start with in the early 1990s. In addition to those standing members, we also have a representative from the West Virginia Cancer Registry who serves on the steering committee. And then we have elected leaders, and those include a chair and a chair-elect. So every 2 years, we elect a chair-elect, and after 2 years of service, that person rolls into the chair position. And we have that for both the coalition as a whole, and then for the 3 standing subcommittees. So we have a prevention, early detection, and quality of life subcommittee, and those are led by chairs and chairs-elect. And then we have one additional person who was elected, but as our chairs roll off, they become a chair emeritus, and they serve in that role for another 2 years. So when you think about our leadership, those folks who are in the chair and chair-elect positions serve for 6 years. And we feel like that's provided us with some continuity in leadership over time. And then we have one additional position, and that is an appointed position, and that we call that person our agent of hope. And it's someone from the coalition membership who is a survivor or an advocate, and that person holds that position. And it really it's not a time limit, but we talk about when they're ready to move along, then we appoint someone else. The coalition is facilitated by staff through a subcontract with the Bureau for Public Health's Comp Cancer program. And right now, the WVU Cancer Institute holds the facilitation role for the Cancer Coalition. There are 1.2 FTEs that serve the coalition and make the work of the coalition go throughout the year. Funding for these positions and coalition activities comes primarily from a line item budget in the governor's budget that's appropriated each year through the West Virginia legislature. And then some of the CDC monies flow to the coalition to fund implementation of activities. Additionally, from that money that we receive from the legislature, a portion of that is drilled down through a mini grant structure to our communities, because we want to make sure cancer control is happening at the community level. And this year we actually pushed out $40,000 in small mini grants to people at the local level to work on the cancer plan. So the focus of today, as Mandy mentioned, is looking at partnerships and how can we leverage partnerships to further support the activities of the coalition. I'm going to focus on 3 different projects and give you examples from those. And the first 2 are sort of non-traditional partners, while the third is really looking inside our coalition and thinking about leveraging organizational partnerships that reach beyond coalition membership to help fund activities. So the first is grant partnerships, and many of you are familiar with this. It's where you partner with another organization to obtain funding for coalition activities. We were fortunate to partner with the Patient Advocate Foundation. One of our founding members reached out, the Patient Advocate Foundation reached out to them, and they went together and put together an application for a third-party funder to found the West Virginia Lung Cancer Project. So let me tell you about the Patient Advocate Foundation, and then I'll tell you about the work of the project and how it ties in with Mountains of Hope. The Patient Advocate Foundation is a national organization that's headquartered in Hampton, Virginia. They really focus on providing case management services to cancer patients, as well as some financial support. They also are the lead organization for one of CDC's national networks, the Self-Made Health Network. And that group focuses on cancer control and tobacco cessation for socioeconomically disadvantaged folks. And so we went together, West Virginia statistics, we have a burden of lung cancer in our state, as well as the largest number of adult smokers in the country. And prior to 2015, there was very little infrastructure to address lung cancer in our state. So the application that we put together included money that went directly to the coalition's early detection subcommittee so that they could start working on lung cancer screening outreach. And so for 4 consecutive years, when Patient Advocate Foundation and the WVU Cancer Institute obtained this funding, we were able to fund the coalition at $10,000 a year for 4 consecutive years. And that allowed the early detection subcommittee to really ramp up lung cancer screening outreach in the state. Money was used for education for both providers and the public. They developed some academic detailing models. There was a webinar created that had free CME for primary care physicians. There were a multitude of public service announcements that were created, and all of this culminated in the fall of last year around Lung Cancer Awareness Month, where a multi-component lung cancer screening project occurred in the southern part of our state, where there's a disproportionate amount of mortality related to lung cancer. And they were able to work with actual screening facilities and primary care folks and increase lung cancer screening by 26% in 2 of the lung cancer screening facilities. So we feel like we don't want to overlook the ability of our partners we are not a 501c3, so we have to rely on our founding member organizations as well as other members of the coalition to go after grants on our behalf. So one of the places that I think is often ignored and forgotten is our opportunity to partner with scientific organizations and scientific partnerships. An example of this is West Virginia has a Clinical and Translational Science Institute. This is a multi-million-dollar funded program from the NIH that really brings together, it's the academic home and the catalyst for translational research in our state. And they tend to target priority areas. The West Virginia grant targets cancer, as well as heart disease and the opioid epidemic and emerging epidemics. So I would say look around your state at the universities and see if there are groups that have large funded programs that might be a good fit for your coalition. So this CTSI program actually has a practice-based network that's made up of about 100 members from across the state. Most of those are primary care and federally qualified healthcare clinics. They're a good place to work on community clinic linkage work. Also, part of every CTSA, CTSI, there's a requirement that there's a community engagement and outreach core. And that is how we, the Mountains of Hope, got actually involved with CTSI. Their CEO, Core, came to us and said, we want to do some focus groups around the state. We want to understand what people believe are the greatest health risks in their community. And we also want to gather some information about their attitudes and beliefs around clinical trials and biomedical research. And then the CTSI's primary outcome was to develop a boots on the ground curriculum to train community members on research and to help them become research partners. So they want to create a pool of community members that researchers can approach in the development of research projects. Mountains of Hope was interested in developing policy briefs. So from the data that was gathered from 10 focus groups, geographically diverse focus groups across the state, 10 policy briefs were created and disseminated to communities across West Virginia. Those briefs included an identification of the top community health needs, the community strengths. So we asked people about what do you see as the strengths in your community. It also identified policy implications and then action steps for leaders. And those were disseminated to both the participants of the original focus groups and leaders in those communities, both city and county leaders in all of the areas. And then finally, I don't think that we want to forget that our MOH membership is made up of organizations and individuals who have relationships beyond the coalition. And this came out this year in a really fascinating way when a group of people came together, a subcommittee came together, and they were talking about they wanted to reach the faith-based community, and they wanted to use a curriculum that had been developed and conduct a train-the-trainer event, both with church leaders and parish nurses. And there was really little funding available for this activity. But when the group got together and decided that this was the road they wanted to go down, one of the member organizations said, you know, we have a relationship with one of the banks in probably one of the only major metropolitan areas in the state. Let's see if I can get space donated. And so we obtained training space for free. Someone else stepped up and offered in-kind printing of manuals. And so the manuals for this program, which is a year-long program that churches would be implementing, are huge. And so that cost was then taken off the table. And another member said that they would be able to secure hospitality at a reduced rate. So all those members coming together, sometimes we forget the importance of in-kind, and we look to use our CDC funds or our legislative funds before we think about leveraging in-kind services. So I think it's a great example of thinking about in-kind first and then building on that to improve the programs with the money that we have available. This activity was actually scheduled for the end of April, but as you can imagine, with travel and meeting restrictions due to COVID-19, we have actually postponed this until late fall this year or early spring. And then Mandy asked us to talk a little bit about the adjustments that have happened with our coalition in relationship to the pandemic. And I would say, I'm sure like you guys, maintaining coalition momentum is the #1 concern because we can't gather together. Our coalition meets 4 times a year face-to-face. Today, actually happening right now, is the first virtual membership meeting. Although our coalition steering committee meets via phone call and Zoom prior to this, the coalition has never had a virtual meeting until today. And when I clicked off a little bit ago, it was going full force. So I think we're going to have a good outcome for that. Additionally, this year, we funded $40,000 worth of mini grants, and the timelines have had to change because this spring they were not able to engage in activities. So this past month has been spent reworking those mini grants and the deliverables for that. On a different note, I'd like to recognize the coalition founding member organizations who have really worked to gather grant money as well as donations for cancer patients who've been negatively affected socioeconomically. So money has been made available to patients for travel, food, and housing needs if their households have been negatively impacted by the virus. And finally, I wanted to let you know that we have a survivorship supplement, and many of the deliverables for that survivorship supplement were already virtual. And so they include podcasts and an online cancer support group. And what we've seen over the last couple of months, as we've had a stay-at-home order in place since around March 20th, the activity on those pages have increased exponentially, and I do see that some of the benefits of having to live in a more virtual world is that we're going to find different ways to reach cancer patients and their caregivers. So I want to thank you for your time. I'm going to turn it back over to Mandy, and we'll do questions at the end.
Great. Hopefully I'm not double muted. There we go. Okay. So I am now happy to introduce our next set of speakers from Iowa. We have Kelly Sittig. She is the Executive Director at the Iowa Cancer Consortium, a coalition of more than 400 cancer control professionals and advocates working together to reduce the burden of cancer in Iowa. And she's worked with the nonprofit and public health space for nearly 15 years. Her journey with the Iowa Cancer Consortium began over 10 years ago when she was the first communications coordinator, and she's been with the organization ever since. Dr. Anjali Deshpande is a clinical associate professor in the Department of Epidemiology and director of the Master of Public Health program at the University of Iowa College of Public Health, and her research focuses on organizational and individual capacity building in the area of evidence-based public health practice, with a focus on cancer prevention and control in rural communities. And finally, Tessa Mills is a program coordinator at the Iowa Cancer Consortium. She currently coordinates the HPV, breast cancer screening, and quality of life work groups for the Iowa Cancer Consortium, and she provides support for cancer-related research projects at the University of Iowa. She has the unique ability to make friends wherever she goes, and she's passionate about storytelling to impact health, especially related to sexual health, cancer prevention, and facilitating coalitions. So I am pleased to turn this portion of the webinar over to Kelly and her colleagues.
Thank you so much, Mandy. And I'm Kelly Sittig. I get the honor of starting today, and then I'll hand it over to my colleagues, Tessa and Anjali. First of all, thanks so much for letting Iowa be part of this webinar. We're excited to share some work that has been happening in Iowa and also how COVID has affected our coalition as well. First of all, I've noticed disclosures to share. I have a ton of acknowledgements. I think all of us are familiar with coalition work and with collaborative spaces, and we recognize that there are a ton of people who have to be at the table and who make things move forward, especially in really tough times like this. So all of these that you see here are really just the tip of the iceberg, and these folks will pop up in what I share with you about our coalition structure and our shifts due to COVID-19. So I'm going to share with you just very briefly about how our coalition works here in Iowa, the Iowa Cancer Consortium, and talk to you a little bit about what we've done in response to COVID-19, how things have changed for our coalition and our coalition work. And then again, I'll turn it over to Tessa and Anjali to talk about some really exciting work that they've been doing focusing on rural cancer control in Iowa. First, let me tell you a little bit about the Iowa Cancer Consortium. So we are our state's comprehensive cancer control partnership. Our function, much like many of yours, is to support professionals and advocates who are working in all areas of cancer control to help them find funding, help them build capacity, help them connect with partners, anything that's going to enhance our ability throughout the state to reduce the burden of cancer in Iowa together. We do this in many ways in Iowa. This includes supporting work groups around different cancer control topic areas. We provide implementation funds that support the Iowa Cancer Plan. That process and amount looks different every year, but that is a big piece of what we do in an effort to get dollars out into communities in Iowa. We do revise and implement the Iowa Cancer Plan in other ways as well. Our cancer plan, we're in about the middle of our plan period. We'll start revising again within a couple of years. All of that information is available on our website too. I'll just point that out if you're interested in seeing what our plan looks like. You can find that at canceriowa.org. That web address is on the screen here as well. Our structure in Iowa, our coalition, is complicated, which is why we have this picture that we like to show people. And what this does is it really shows how we have this unique, I think of it as a triad structure that keeps our coalition supported and doing work and keeps partners connected. So what you see here is that in the center is a 501c3. So our coalition, the Iowa Cancer Consortium, does have 501c3 status and has for several years. And that is really at the heart of what we do. But two really important legs to our triangle here that help our coalition function the way that it does include the Iowa Department of Public Health and the University of Iowa Holden Comprehensive Cancer Center as well. If you follow the arrows here with me, you'll see how we use funds that we get through the Department of Public Health and how they interact with our different pieces of our structure here to make our work possible. So the poll that Stephanie shared at the beginning asked which coalition has funds beyond the CDC dollars. And we are very lucky to be one of those coalitions who does. So there are two pots of money that eventually affect the funding that our coalition sees, and those both come through the Iowa Department of Public Health. One is the CDC Comprehensive Cancer Control funding, and then in Iowa we're very lucky to have a state budget appropriation, and we have for years, that supports comprehensive cancer control efforts. Those two pieces of funding, we get pieces of them. They're distributed to us through a competitive grant, 5 or 6 years from the Iowa Department of Public Health. And that is basically to revise and implement the Iowa Cancer Plan, to deliver an implementation grant program, and basically support an infrastructure of collaboration within cancer control in Iowa. So those dollars come to us. You can see the implementation grants at the top. That's one place that we put money out into communities to help do local and statewide cancer control. But another key piece is that our 501c3, our nonprofit organization, also subcontracts with the University of Iowa in Iowa City, and specifically the University of Iowa Holden Comprehensive Cancer Center. So we pay them, the 501c3 pays Holden a little bit of money to pay our salaries for our staff and HR services. So if I were to explain this as simply as I possibly could, I would say that we are a 501c3 that's funded primarily by the state and housed at the University of Iowa and staffed by University of Iowa employees. I know it's probably clear as mud, but if you have questions, feel free to chat with me and I'll try and clarify. A really important piece of this relationship that we have with the University of Iowa as well is that because our staff are University of Iowa employees and Holden Comprehensive Cancer Center employees, the university is able to pay for some of our staff time when the opportunities are appropriate and that's a good fit off of their P30 funding. So we have had staff support for several P30 supplements, including one that you'll hear about today from Tessa and Angeli. And that is just another way that we're able to diversify our funding, support some staff time, but also contribute to different cancer control efforts across the state. And I think it's a benefit as well for the Cancer Center because our consortium is really the link to communities in Iowa. So a little simpler is our internal structure. As Mandy mentioned in the introduction, we have more than 400 official consortium members and a network that extends up to 1,600 folks in Iowa who are interested in cancer control. We do have an official membership structure, and this is how our structure works. So individual and organizational members, and we have about 50 organizational members right now, participate in work groups and committees. Our work groups change from year to year depending on the interest of our members and the state of cancer control in Iowa, what's happening in the world. The ones that you see listed here are the topic-specific ones that are meeting right now. But again, those do change. We want to be responsive to what the interest and needs of our members are. And then our committees really support more the internal functions of the coalition itself. We have a board of directors, a traditional nonprofit board of directors that's made up of members of the consortium and elected by members of the Iowa Cancer Consortium. And then you can see we do have a staff that supports coalition activities at all levels. Right now, our staff is at 4.45 FTE, as you can see there. That changes depending on funding availability. I'll also mention that about a full FTE of that is supported from non-Iowa Department of Public Health funds. So this would include additional staff time supported by the Iowa Cancer, the Holden Comprehensive Cancer Center as well. So it's just one way that we're able to stretch dollars and resources from the state to grow those and make our staff and then comprehensive cancer control efforts even more robust. So the partners of this session, the planning partners, asked us to talk about what's changed for our coalition due to COVID-19, and there are just a couple things I want to mention. The first is the general changes that we've had to make since the virus started really affecting our ability to get together, started affecting the economy here in Iowa, started affecting how healthcare services are delivered. When we started shutting down and asking people to socially isolate here in Iowa, we had some pretty quick effects that had to take place. One is moving our 3 regional spring meetings to virtual platforms. We try and get out in different regions of the state every year for our spring meetings. Those obviously had to move virtually. And I will say we had some of the best attendance we've ever had on those. We decided to maintain our work group meetings, letting our partners know that there was not an expectation to attend if there were more pressing matters. We wanted to still continue some sense of normalcy and offer a place for folks to get together and talk with their peers, find some support. And that's been very well received. We have had to pause our call for invitation for proposals for fiscal year 21, so this upcoming fiscal year implementation grants, simply because we are still waiting to hear what our own state funding will look like for this year. We also have changed the priorities for that, our planned priorities, if the funding is available, to focus on and include supporting populations that are the most affected by both cancer and COVID-19, asking for projects that look at creative ways of delivering cancer services in light of the new state of things that COVID-19 has brought, as well as just an overall focus on equitable cancer care delivery. One of the biggest changes we made, though, is to look at our current fiscal year budget. So fiscal year 20, our fiscal year ends June 30th, so we're coming towards the end. But once it was clear what an impact COVID was going to have on cancer and the state and the economy and just people in general, we realized that some of the work that was happening wasn't going to be able to be finished or that there were more urgent needs arising that we could help with. We did a quick, very unscientific survey of our members and partners just to take the pulse, basically, of what the urgent needs they were seeing were based on coronavirus. And what we heard was transportation and lodging for cancer patients. And our board was, had given the direction, which was wonderful, that they wanted to do everything possible to support those urgent needs of cancer patients, that should be our focus in the immediate time. So knowing that, and because we had partners on board who already had wonderful relationships in public transportation and lodging, we were able to shift about $40,000 in our current fiscal year budget and launch what we call the COVID-19 Transportation and Lodging Initiative. Keep in mind, this is just a few months. So this would be between basically April, May, and June, this initiative, because these are current fiscal year funds. One of our implementation grantees was, in the past, was the American Cancer Society, a transportation and lodging staff member who had deep relationships with public transportation and lodging in different parts of the state. And she's a strong partner and member of the consortium. And she was willing to help us reach out to cancer centers, hotels, and public transportation to set up a project. So what this ended up looking like was we worked with Casey's General Stores to purchase $15,000 in gas cards and got those distributed to 19 cancer centers and hospitals in Iowa based on their need and their patient load. Casey's donated a few extra gas cards, which was wonderful. We also subcontracted with various public transportation entities in Des Moines and the Quad Cities. There was already some funding happening with transportation in Iowa City, which is why that isn't listed here. That was happening through an implementation grant, but we put $12,000 more in public transportation. And then we put about $12,000 towards lodging in Des Moines and Iowa City and worked with hotel partners for a reduced rate for cancer patients. And then we pulled everybody in the communities together, including the cancer centers, talked through how the referral process would work, and everybody, we kind of put our hands in the middle and said break, and everybody kept going on their business, and we're able to help cancer patients right now have lodging and transportation, continue their access to care, and hopefully feel a little less burdened. And I put this key takeaway because I think that this is the perfect example of what a coalition can do. We were able to make a really swift shift in our resource allocation and do this new initiative very quickly because of the relationships that already existed in the coalition. We had partnerships that were primed. We didn't know COVID was coming and that we would be focusing on transportation and lodging because of it. But because of the partnerships that were in place and the projects that had been underway for a couple of years, it was perfect timing, and things were in place to make this a success. So I think sometimes we get stuck. We'll have a work group and we think, okay, we don't have any guys to work on right at this moment, or maybe our project has wrapped up and we're not sure what to do. But I do think that this shows the benefit of keeping those relationships warmed up and at least connected, because when the moment strikes, they can be very, very important. And that's a key lesson for us from COVID. It's a lot of information in a very short time, but I want to make sure that you hear from my awesome colleagues who are here as well and are going to talk about a longer term project that's been going on quite a while. So I'm going to turn it over to Tessa Mills to talk a little bit about rural cancer control.
Hi, thank you, Kelly, and thank you everybody for allowing Iowa to kind of share their success stories and what we've been working on. So as mentioned in my introduction, my name is Tessa Mills, and I'm a program coordinator with the Iowa Cancer Consortium. And for the last couple of years, I have been working with the University of Iowa and the College of Public Health on this, what we're calling a P30 rule supplement. And And I kind of am an informal presenter, and I like to share information kind of through storytelling. So I'm going to kind of go back to 2018. And in 2018, the Holden Comprehensive Cancer Center received a supplemental grant from the National Cancer Institute to really focus on building capacity within rural communities to improve cancer control and prevention. And so when we received funding, this was really a partnership, not only with the Holden Comprehensive Cancer Center, but also with the College of Public Health and with the Iowa Cancer Consortium. And our main goal was really to reach out to critical access hospitals in Iowa to help them improve cancer control and prevention. We know that there are a lot of rural versus urban disparities in cancer control and prevention, and so we really hoped that by developing these relationships, we could help provide some technical assistance or some support for these hospitals to serve their communities and improve cancer control and prevention. So when we set out on this project, we really had 4 main goals. So first and foremost, we wanted to develop partnerships with at least 6 of the critical access hospitals in Iowa. Now, Iowa is very rural, and we have around 83 critical access hospitals across the state. And our second goal was to conduct some community surveys in these 6 critical access hospital communities. And the reason that we wanted to do that was we wanted to be able to provide some data for them to be able to use, whether that be for their community health needs assessments and for selecting priorities around cancer control and prevention. And our third goal was to provide webinar trainings in implementation science. So there are a couple of members of our research team that are experts in implementation-based sciences. And so what we wanted to do is we wanted to be able to provide some training via webinar for these hospitals so that they could select some priorities and get some training around how to implement some strategies that would help them meet their goals. And then our final goal with this supplement was to create a rural cancer research network. And that's something that we're in the process of right now that Dr. Anjali Deshpande will talk about here in just a minute. But those were kind of the 4 overarching goals that we had when we set out on this project. And so what did we do? The very first thing that we did was we set up virtual introductory meetings with, we reached out to several critical access hospitals. And of the folks that were interested in meeting with us, we set up very quick 30-minute introductory meetings with them just to talk about the project and some of our goals and to see how we could really help support them in improving cancer control in their communities. The other really interesting thing, well, I guess I think it was interesting that we were able to do was we partnered with the Iowa Cancer Registry and created some hospital and community cancer profiles. And these were very, very data-rich documents that we were able to give to these hospitals that we met with. And some of the data in these reports included things like some of their top diagnosed cancers at their hospital, how far patients were traveling to the hospital to get care or treatment. And then we also had some behavioral health information from BRFIS data that we were able to give to the hospitals that, again, they could use for community health needs assessments and to also help them select priorities. After that, we did in-person visits. So we were able to recruit 6 critical access hospitals, and we hit the road and we went out and we visited with a lot of their leadership and key staff at those hospitals, where we were able to actually give them a physical copy of these hospital and community cancer profiles, get to meet them in person and get to know a little bit more, not only about their hospital, but about their community and, you know, things like employers, schools, and things like that. So it was really, our intention was really to develop good, solid partnerships with these critical access hospitals. And so after developing these partnerships, there was a few kind of immediate outcomes that we were really excited about. And one of them was in one of the communities that we partnered with their critical access hospital, we also connected with the local community college in their area. And this community college works very closely with their critical access hospital through a program called UR Med. And what that program does is they allow undergraduate, especially pre-med students, to really shadow with these rural providers at the hospital to kind of expose them to what it's like to work in a rural healthcare setting. And as part of that connection, we were actually able to partner with a biology professor and one of his students, and one of his students was able to train with a research team member on our project and learn about how to conduct interviews with providers in her community. This county had very low HPV vaccination rates, and so she was able to then go into her community and interview healthcare providers about what some of their perceived barriers were around vaccination. And so it was kind of an unexpected outcome, but it was really a great partnership, and it was helpful for the community to kind of learn, okay, here are some driving factors as to why our vaccination rates might be low. The other outcome is we were able to grant the 6 critical access hospitals organizational memberships to the Iowa Cancer Consortium. So not only were we able to create partnerships with them through this research, but we were also able to plug them in to the Iowa Cancer Consortium through organizational memberships. And then another additional outcome was the Holden Comprehensive Cancer Center during this time was working on putting together a community advisory board. And since we had already developed some relationships with critical access hospitals in rural communities, there were several key players that we felt like would have been great fits for the community advisory board. And so we were able to take some of those partnerships and recommend them for participating in this community advisory board. So lots of different immediate outcomes that we were able to put together as part of this project. And so now I'm going to turn it over to my colleague, Dr. Anjali Deshpande, and she's going to talk a little bit about some of the COVID adjustments that we've made to this project and what we're working on right now.
Very quickly, some of our adjustments that we made with regard to COVID-19 with what we were doing. We spent about a year and a half, as Tessa described, working with the 6 community critical access hospitals. And we were just at the point in sort of the January, February timeframe where we wanted to launch a community-based survey in each of the 6 communities that we're working in, centered around looking at community perspectives, knowledge, attitudes, and behaviors related to cancer. And of course, then COVID-19 hit. And we thought, well, now what are we going to do? We have the survey that we need to launch. How can we use that survey to try and get information for these communities related to COVID-19 topics? And so we're currently in the process of launching the new survey that includes things around COVID-19, including how people being quarantined, people being at home has affected their access to cancer care, other kinds of behaviors related to cancer treatment, as well as involvement in survivorship groups and so on. And so we've been able to expand that survey. We've also been able to expand our partnership with other cancer centers that have this rural supplement grant, so that we can try and do a concerted effort and look at how COVID-19 is impacting cancer care, cancer prevention and control across different cancer centers in different regions. Tessa mentioned also these webinar trainings in implementation science that we are wanting to do with the critical access hospitals. And one thing that we've decided to do, as we've done in a lot of other areas that we work in, we're putting these webinar trainings online. So what was meant to be a very involved and collaborative effort with the critical access hospitals, for now we're going to be putting the webinars online so that the hospitals have access to this kind of training. All 6 hospitals have indicated, that they have a very limited capacity to be able to do the projects that they intended to do, but they definitely want to be able to get the training and to be able to get back to those projects as things start to settle down, hopefully later in the fall with COVID. The other thing is that we wanted to shift the focus of what we were doing. We know that cancer prevention and control is important to these critical access hospitals, but right now they're fully working on patients, people in the community that need their support. So how could we shift our focus to providing COVID-19 support to the critical access hospitals, particularly by providing resources, by helping them provide resources. One of the things that we're doing in particular is to be able to provide videos and information in a variety of languages that the critical access hospitals can share with some of their special populations. Perhaps the most important thing that is coming out of this work that we're doing with the critical access hospitals is our desire to take what we're learning from these 6 hospitals and use that as a starting point to expand beyond those 6 and to be able to work with the consortium to include other critical access hospitals as well as other partners across the state in building a rural cancer research network. And we have a very inclusive definition of research, not only to be able to bring people into clinical trials, but also to do research on health services and research across a continuum of cancer prevention and control. In addition to building a research network where we can connect with universities, with critical access hospitals, with public health organizations across the state, a critical aspect of this is to build capacity across relevant stakeholder organizations and groups so that we can get diversity and variety in the kinds of organizations and partners that engage in cancer prevention and control work. I'm going to sort of cut things short right there to say thank you for including Iowa and the Iowa Cancer Consortium and the University of Iowa in this webinar so that we could share a little bit about what we're doing in rural cancer prevention and control and how we've been able to leverage some of the partnerships that we have in Iowa. I will turn things back over to you, Mandy.
Thank you so much. That was great. So I want to thank our presenters again. I don't see any questions that have come through. If you have a question, let me know. I think Ruta is monitoring that, and I should be able to see if you put something in. So I'm going to go through this resource for you and provide a couple of announcements, but I think we have one question. How is Kelly Siddig with Iowa Cancer Consortium able to choose the cancer centers and hospitals to distribute gas cards to? So why don't we go ahead and ask that question while we still have our Iowa folks, and then we'll move on.
Hi, yeah, that's a great question, and it's something we thought about really carefully. Our criteria ended up being, first of all, we got a list of centers that we knew served at least 100 cancer patients per year. We looked closely to make sure we included all of those that had COC accreditation. And then our final criteria was we really looked to make sure that those centers that were getting gas cards, or at least most of them, offered radiation services because it was the experience of our partners that really created one of the biggest burdens.
All right, thank you so much, Kelly. That's great. It doesn't look like we have any other questions, and we have only a few more minutes, so I wanted to leave you all with a resource. So I always like to make sure that people are equipped with something that they can put into action. So Ruta will be sending out via email to all of the people who registered for this resource planning matrix. And I have to acknowledge the national partnership. I took a adaptation of something that we use in the national partnership to think through maybe some of the things that you all at the coalition level might need in terms of infrastructure support, planning, implementation, policy and systems change, meetings, activities, evaluation, and communication efforts, and try to kind of think through what some of those resource needs might be at the coalition level, and then what some resources and partnerships might look like, so that it's always helpful to have a grant from CDC or from your state, But in some cases, some of these resource needs might be filled with talents among your coalition members or networks, people that know other people or have communication channels or lists or other kinds of non-traditional partnerships. So just something to kind of get you going that you can modify to fit your coalition to try to help you think creatively during a resource-constrained time around possibilities and partnerships. And then, of course, we want you to save the date for the second part of our two-part webinar series, Maximizing Coalition Sustainability Through Partnerships. So June 23rd, 1 p.m. Eastern Time, we'll have our second part of this two-part series, and we're bringing in two subject matter experts to speak to you from an international context about kind of value propositions and public-private partnerships that might give you some other creative ideas around partnering for coalition sustainability. And then I do want to ask you to take a few minutes to fill out our evaluation. Your feedback helps us improve in terms of what we do and how we do it. So you should see the SurveyMonkey link in the chat box. And so, Ruta, if you could put that in the chat box for me. You won't be able to click on the link on the slide, but you can in the chat box. And if you just take a few minutes to do that, we would greatly appreciate your feedback. So you should be hearing from us from the chat box. You'll have the link there for the evaluation, and then you'll also get an email from us with the resource matrix. So we hope to see you on our second webinar. Thank you so much. I think we had about 85 people attending, and it's nice to kind of engage with you all virtually. So thank you again. Thanks for your feedback. Thanks for your engagement, and we'll see you on June 23rd.